Medicaid's enormous evolution over now 51 years, which in my mind is really a testament to poverty in the U.S. and market failure for the sick. So if you think about all of the examples that Cindy offered, what you see is this recurring theme of Medicaid as an unbelievably flexible, for a behemoth like Medicaid, unbelievably flexible first responder to whatever the problems of the moment are. And if you look at the history of Medicaid reform amendments, everything from breast and cervical cancer to pregnancy without access to insurance to the need for a pediatric system to cover low-income children, and you just see these themes again and again. Medicaid is a testament to poverty and market failure. The second point, just to follow up on Cindy's discussion of NFIB versus Sebelius, which of course was the case in which the court upheld the individual mandate in the Affordable Care Act while striking down the mandatory Medicaid expansion as unconstitutional. I always think to myself that it's one of those situations where the Chief Justice, John Roberts, who of course authored the opinion, with a little help from his colleagues, was totally wrong on the law when it came to Medicaid. He decreed that the Secretary couldn't enforce the expansion because it was a new program, and you couldn't condition funding under the old program for compliance with the new program. Of course, the expansion was not a new program at all. It was simply an amendment to the old program. But he was totally right on the realities for all the reasons that Cindy says. If you look at Medicaid in 1965, it's nothing like Medicaid in 2016, and he called it, and he was correct. He had a very eloquent way of saying it, even as he undid the expansion, that it went from being a program for very poorest people and for welfare beneficiaries to a critical element of the national health insurance system. And finally, I think Cindy, as she always is about everything, is exactly right, that what we're seeing now is a fight between an old welfare vision, a vision driven by largesse, theories of largesse, theories that the poor are entitled to nothing, that whatever they get out of the beneficence of the political process that happens to give them something, with very marginal expenditures, and on the one hand, and on the other hand, seeing Medicaid as what the Chief Justice said, which is a critical element of a national health insurance system. And that's the struggle that's going on. We're seeing the struggle now. We're seeing sort of a rehearsal of sorts of what's to come, depending on the outcome of the 2016 elections. We're seeing it, as Cindy pointed out, through the 1115 demonstration process, and of course in bills before Congress. So with that, why don't I turn it back over to Cindy and let her take questions and you all engage in discussion.
Comments, questions?
So if there are questions, please introduce yourself first.
Hi, I'm Naomi Seiler in the department. Do you see any effect? I know that Section 1332 waivers are not waivers of Medicaid requirements, but of marketplace and other requirements. But do you see what do you see as the potential impact on Medicaid or on otherwise Medicaid eligible, Spanish populations, et cetera, of those waivers as they come into effect?
So just to level the playing field on 1332, it's another waiver authority it's a new waiver authority in the Affordable Care Act. It doesn't kick in terms of effective date until 2017. 2 states are now pursuing 1332 waivers, but very narrow waivers, Hawaii and Massachusetts. It essentially allows states within very clearly, well, not clearly defined, but very apparent guardrails to basically change the rules of the game around the private insurance, individual small group market, even the premium tax credits themselves. So there have been debates about whether or not in any given state that hasn't expanded, even though 1332 deals with the marketplace, does it give an opportunity to say, we're going to just get rid of Obamacare. We're going to do 1332 and maybe an 1115 waiver, combine them, do our own thing in even a bigger way than 1115 has let us do. and free ourselves from Obamacare and therefore, have the political space to go ahead. I think that there are people who are talking about that. I think when they get into the nitty-gritty of what 1332 is and requires, if you're going to do something significant, it is a very significant undertaking. And these are generally for states that have said, I'm not doing a state-based marketplace, I don't want to get into that business at all, and suddenly they'd be saying, I'm going to do my own version of Obamacare. And so it's a big leap. And so while I don't want to say that that's not going to happen, because I know people are continuing to think it through in at least a few different states that haven't expanded, I think it's going to be a hard lift.
Do you think those guardrails, are you concerned the guardrails could shift under, a different president, but a very different president?
For sure. The guardrails are in statute. The administration put out a sub-regulatory guidance on it and took the occasion, I would say, I think it's fair to say, to be as guarded on the guardrails as they could be. I think a new administration, actually I think probably Democrat or Republican, might relook at that guidance. And then a very new administration could take those guardrails in a different place. But they're not insignificant. I mean, it basically says, for example, you can take 1332, but you can't, benefits cannot be reduced thereby. So could you say, well, in the aggregate, but for some group of people they could be changed, and other group of people, they could be raised and lowered. Same thing about cost sharing. The out-of-pocket costs for individuals can't be changed. Well, okay, but could you change it over here and not change it over here and do it in the aggregate? So I do think that there's room for administrative interpretation, and that depending upon how different the different is, we could see a new administration come at it in a very different way.
Yeah, I'm Abidor. I'm in the department also. I'm an economist, so I was going to ask a question about dollars or distributional question. You mentioned that there are proposals now in Congress and various committees to either cap benefits or increase cost sharing. How about rolling back the subsidy limits? So the subsidies that sliding scale that you showed goes up to 400% of the poverty line. Some might argue, not me, but some might argue that 400% of the poverty line isn't all that poor. We're talking about close to $80,000 per year per individual, if I have the numbers right. And that a relatively easy place to adjust the level of benefits and roll back the costs would be targeting the sliding scale.
Well, so I think it's all a really good question and good points. I neglected to mention a kind of key issue that's floating around the 2016 elections, which is to repeal or replace the whole marketplace, and including the premium tax credit structure. So one could imagine a total repeal and not having any kind of subsidies available for purchase of individual or small group coverage. Or you could see, and we've seen some have suggested, that the premium tax credit be substantially reduced and not extended up to that income level and thinned out even below that. So I think, I think it's going to be very difficult to think about repeal and replace that politically, substantively. That being said, it seems to me that at least on the Republican candidates have also strongly stake that out as a part of their platform, that'll be hard for them not to come up with something.
It seems to me like this might be one area of compromise, where the Democrats might go along with a 300%.
I think the compromise, would be more if there's some evidence emerging that at the lower income level, the subsidy isn't deep enough to help people purchase the coverage. So, whether there could be some trade-off that you don't you need less subsidy between 300 and 400, but more subsidy between 138 and 250, and to smooth out some of the cliffs. So there, it is, was it 6 years ago, almost to the day, the law was passed, and it is an enormous piece of legislation, very complicated, and very much, one would think in the normal course of business of administering laws and implementing very big change, a work in progress. There are many things people of reasonable minds could get together and say, well, how about this and how about this? So I think the question is whether the atmosphere around the Affordable Care Act will be such that some reasonable discussions and compromises can be had, or it's, no, we're not going to do anything to make it easier. We only want to do something that makes it less effective or less costly.
I'm an assistant professor at the Department of Health Policy and Management. I have a question about the primary care physician participation in Medicaid. A big question during the expansion is, we are facing a shortage of primary care physicians, and on top of that, not all physicians accept Medicaid patients. So this partly is, depending on the state's policy, the reimbursement policy. But at the federal level, is there any, can you comment on this issue and any guidance and policy from the federal level?
So there was a 2 year, as I'm sure you know, bump given by the Affordable Care Act of raising up primary care rates in the Medicaid program to the Medicare levels, with the federal government paying for that differential. Some might say, why was it 2 years? Because that's all they were able to pay for in the bill, not because anybody really thought 2 years is like magic. There was some hope that some states would pick it up after that. Some states have, but not the majority of states. And the other development in that area is that the Supreme Court made a decision last year, right? Armstrong versus Exceptional Child, on that providers no longer had a private right of action to sue if payment rates in the Medicaid program were, or if they alleged that payment rates in the Medicaid program were inadequate. That then puts more onus on the federal government, which was the argument made by the plaintiffs, by the defendants, like, oh, well, the federal government should just take care of that and make sure that there's adequate access. So it ups the ante for the feds to be really looking at whether there are adequate supply of caregivers throughout the system, and if so, what they're going to do about it in terms of requiring rate adjustments. There's a set of regulations that HHS issued a few months ago on fee-for-service rates, and they also did a request for information saying maybe they're going to do a little bit more policy making in this area. And there's new regulations that will be forthcoming, final regulations in the managed care area in terms of adequacy of the networks. So I do think over the next period of time there needs to be more scrutiny and analysis of how well access is working for people, and then questions as to whether or not the federal government will step to the plate more than it's done in the past because of the lack of any private right of action. And we've also seen, of course, a continued increase in funding for federally qualified health centers who have been so critical in terms of providing those services, and particularly for primary care services. So I think that's another important part of the equation is, how will that funding fare over the next period of time? Yes. Hi.
Jeff Lee from the department. So that little wheel you had, that part of the wheel that was healthier communities, curious what you see the parameters of that. I mean, that's shorthand for thinking about social determinants, and what is the role of Medicaid? Is it, assuring access to those social services, whether it's housing or nutrition or whatever? Is it paying for some of those social services where there's a gap in a community? How far do you see that going? Because ultimately, if you think about social determinants, you could healthize almost anything, and then Medicaid could run the world, which may or may not be a bad thing. But so what do you see within both the capacity of the program and the law, what the sort of limitations are?
The law says that the Medicaid program shall pay for medical assistance. The law also says it shall not pay for room and board. Obviously, it does in the context of nursing homes and hospitals to some degree. So there's some limitations on it. There's also opportunities to go further through 1115 waivers. I do think that there, I'll start off by saying I think the first fair hearing I did, so fair hearings are what you do when you have a client who's aggrieved by an action by the welfare agency, Medicaid agency, and I think one of the first hearings I ever did, I was in college, was got a doctor to write a prescription for more food for a very poor family who ran out of food at the end of every month, and said Medicaid should pay for it because it certainly wasn't keeping them healthy. And I lost that hearing. So I get the temptation to Medicaidize everything. I don't think the law or the politics will support that. I think we will. I just don't think it's wise or realistic to think that Medicaid is suddenly going to pay for housing. That being said, I think there's a lot of platforms and supportive services that Medicaid can pay for. There's some things that have been thought of as more public health initiatives, as you well know, that Medicaid has been able to figure out how to pay for, like around smoking cessation and programs, for example. We just saw the secretary give out a waiver in Flint, Michigan for remedying lead in the water. So I think there's opportunities to be thinking about certainly integrating areas of financing and at least somewhat on the margins, but not insignificantly, Medicaid stepping more to the plate. I also think there's a big opportunity to, CMS has gone farther than it has in writing forever to say managed care organizations, and most of the beneficiaries in Medicaid are in managed care. Managed care organizations don't have to be guided by those rules. So if a managed care organization thinks that an intervention is going to save them money and is good business, they can take their Medicaid capitated rate and they can go buy the air conditioner. They can go pay for the first or second months of rent. They can do it, some kind of renovation on the home to make it more accessible so that people can, go in and out and take jobs and whatever else, be more integrated with the community. So we've seen some of that. Again, they're going to. There's only a limit as to how much that's going to happen. They have to decide that it's cost effective. But we've been working with one state that. Where the managed care where the state really wants the managed care organizations to do this, but then doesn't want them to lose their premium as a result because they're having less hospitalization, so then their premium goes down. So we're making some progress on that to think about how to balance those interventions and say as long as it's a cost-effective intervention, your payment rate doesn't necessarily go down. So I think there's a lot of opportunities, but I don't think we can Medicaidize the world. I know we're running out of time, but.
Yeah, it's a little past one, so why don't we let this be the last question?
Thank you. My name is Steve Bowden. I'm an MPH now policy student here. I'm also a research assistant with the department. Post-ACA, what would you say the role has been or the impact has been for Medicaid presumptive eligibility, and what role do you think it will play going forward?
It's a really good question. So Medicaid presumptive eligibility is a process by which somebody can go into a provider, healthcare provider, or in some cases, depending upon state option, could be a school, could be a child care center, and sign up for Medicaid presumptively. So it looks like you're eligible. You don't have to go through the whole application process, and you can get benefits for a period of time until your full application is determined. And the presumptive eligibility option was strengthened. The Affordable Care Act actually requires hospitals to do presumptive eligibility. There are some states that say, it's not the best strategy right now because if I can get my IT systems to work and people can get on coverage right away, then that takes the need for presumptive eligibility away, but it avoids the problem where somebody applied for presumptive and then they didn't finalize the application, so they lose coverage later. So I tend to be someone who thinks that there's a time and a place for all of those tools, that there are some individuals and some facilities where it really helps to have that hand-on assistance and to use presumptive eligibility. But I do think that real-time eligibility determinations has made it less of a universal approach than perhaps it might have been 3-4 years ago. So I think with that,
So thank you very much, Cindy.
you're welcome.